I'm Bernardette Arellano. I'm the Director of Government Relations for the California Children's Hospital Association, and I'm going to, first of all, I'd like to thank the Lucille Packard Foundation for Children's Health for putting on this briefing, and also to Assemblymember Pan and his office for really raising this issue up to the legislature and to broader public attention. So I'm going to be covering just the basics of state programs for medically complex children, who's covered and who isn't. The California Children's Hospital Association represents the 8 independent children's hospitals in California. And as was mentioned before, all of our hospitals are actually CCS providers, and we have a lot of special care centers, and we really treat children in the most complex and medically fragile conditions. So we have a lot of experience with the insurance coverage or lack of coverage for children with special health care needs. I'm going to be going over children's insurance coverage in general, insurance by state program, and then I'm going to talk about covering children with special health care needs, private health insurance, challenges there, the CCS program, which is really the most complex and medically fragile population, and then talking about the population moving forward. So sorry, I'm missing a couple words there. So the basics, as was stated before, there are 9 million children in California. More kids are publicly insured than privately insured, and compared to the United States in general, California children tend to be have a higher risk of being uninsured and also of being reliant on public insurance. Just going to restate, 1.4 million of those 9 million children have special health care needs. So for sources of coverage, you can see here that children are less likely than adults to be covered by their parents' insurance or employer-based coverage, much more likely to be covered by Medi-Cal Healthy Families or other public programs. So I'm going to be talking about the breakdown of this population first. You can see here Medi-Cal really dominates the insurance market for children. We have a smaller group of Healthy Families children here, and those are obviously transitioning right now into the Medi-Cal program. The CCS population is a much smaller subset, but as I said before, those children are the most medically complex and fragile, and really the program is accessed through Medi-Cal and Healthy Families, as well as having children who are covered through CCS alone. The rest of these programs tend to be county-based only, or it's the Kaiser Healthy Kids program. So in covering children with special health care needs, private versus public, I apologize, this is a little bit older data, but as was stated before, more kids have private insurance in California than nationally, and private insurance is usually viewed as much better and richer than public insurance, but even so, about 40% reported inadequate coverage in 2010. I think what was covered earlier was the definition of inadequate coverage. This is a breakdown of the private health insurance market for all people in California. This isn't just children, but I think you can see the dominance of Kaiser in this slide, and also the coverage for Kaiser is HMO coverage, which is the penetration in California is much higher than the rest of the nation. So why is private health insurance sometimes inadequate for kids with special health care needs? Well, networks and benefits vary between providers. The broader and richer the network, the more expensive the plan. Health insurance products tend to primarily focus on adults. Information about coverage might not be available when parents select a plan. Hopefully that will change under ACA. But it's still a really complex business picking a healthcare plan. I know I got my healthcare benefits information a couple weeks ago, and I think it was about 1.5 inches thick, and it was in like 8-point font. So parents may select a health plan before they have or adopt a child, and so they don't know they're going to have a child with special healthcare needs, and they might pick based on price and have inadequate coverage. Finally, employer-sponsored health plans might not cover dependents. You saw that distinction between employer-based and employer-based health care for kids versus adults in a previous slide. So for the children who are in the public health insurance programs, what are the options? There are about 8 public health insurance programs for children in California, and they all have really different eligibility requirements. I'm not going to go into them all here. I think everyone's probably familiar with the breakdown, but really it's covering a lot of children up to about 300% of poverty. Less medically complex children can access services through standard insurance products, and also there are other programs that support particular conditions and provide other treatment. But the sickest and most medically complex end up in the CCS program. So as an overview of the CCS program, it's more than insurance. It provides diagnostic and treatment services, and it really it coordinates care for children up to age 21. It's administered as a partnership between the state and county health departments, but really is the county health departments are really responsible for the bulk of care for the CCS children and for determining the kind of services that they access. It's funded through a combination of dollars, and kids access the program in 3 different ways. They can be CCS Medi-Cal, CCS Healthy Families, or straight CCS. Care for CCS conditions is carved out of managed health care plans in most of the counties in California, except for 5 counties where it is carved into the Medi-Cal managed care. This is just a graphic demonstrating the CCS eligibility requirements. Family income, kids have to be under $40,000, or their families have to have an out-of-pocket cost greater than 20% of their family's gross annual income. For CCS Medi-Cal and CCS Healthy Families, they access the CCS program through their eligibility for Medi-Cal and Healthy Families, and with the identification that they have a CCS eligible condition. And I'll talk a little bit about that in the next slide. For those 2 populations as well, they have to be U.S. citizens or permanent residents. And for the purposes of reimbursing providers, the Medi-Cal managed care covers the preventative and non-CCS related diagnoses, and the CCS conditions are covered through fee-for-service. As you can imagine, this can present some difficulties with coordinating care for this really complex population. And for the CCS-only population, this is really a mixture of uninsured children. There are very few otherwise uninsured children, undocumented, and then other people with private insurance whose out-of-pocket costs are very high. CCS eligible conditions, I think, the definition is really closely related to the definition for the children with special health care needs, but they're specifically problems that are physically disabling, need to be treated with medicine, surgery, or rehabilitation. It's very broad. Some children are in the CCS program only for a year or for a short amount of time, or go in and out. Others can be in the CCS program until they turn 21 and they age out and either can access the genetically handicapped persons program or move into private insurance or into Medi-Cal for adults. So I just have a couple of examples of CCS eligible conditions here: congenital heart disease, cancers, hemophilia, and sickle cell, spina bifida, cystic fibrosis, etc. CCS is really special because the centers and the physicians and the hospitals that treat the children are really highly specialized, highly qualified, and go through a really rigorous qualification process and are required to keep up the qualification through a lot of rigorous standards determined by the state. So CCS provides case management, referral and connection, and also services available through treatment centers and connection to other state and county agencies. These children, their families are, in general, very low income, and so they might require access to social services, transportation, other services like that. So it's very important to have that case management and connection. So looking ahead, even with CCS available, almost 1/4 of children with special health care needs have conditions that cause financial hardship for their families. 28% of them have families that pay $1,000 or more of out-of-pocket medical costs annually. And that might not sound like a lot, but for a very low-income family, $1,000 out of pocket annually it can be, a full 10% of their annual income. That's a lot. There are also persistent shortages in pediatric subspecialty due to low reimbursement in the Medi-Cal program, and also just a general lower number of pediatric subspecialists. In the pediatric world as compared to the adult world, there's actually a shortage of subspecialists and a relatively good availability of pediatric general practitioners. So there's also a need to protect and improve this medically fragile population moving forward, particularly in the new Affordable Care Act environment. With hospitals transitioning to risk-based payment models, this puts hospitals at risk for these higher needs patients. We also need to consider the needs of the medically fragile when designing integrated care models. And the health benefit exchange will really be important for children who transition in and out of Medi-Cal eligibility, and and determining the accessibility of care when their parents are selecting plans within the health benefit exchange. Finally, the Section 1115 waiver contained the previous Section 1115 waiver that's currently in effect contained CCS pilots, and hospitals and counties and providers are currently involved in modeling different ways of managing the CCS population. So we still need to see what the result of those pilots are, and make sure that in planning the future of the CCS program that we really maintain the high level of service that they currently get. Thank you.